Welcome to SurgiColl, the podcast. SurgiColl, which is short for Surgical Collective, is the first open access journal focused on publishing the latest evidence-based literature on the surgical specialties. The journal publishes quarterly and includes peer-reviewed original research, systematic reviews, current concept reviews, case reports, and surgical techniques. Today, I'm looking forward to our discussion on the most recently published issue of SurgiColl, where we're going to focus specifically on an article called Advances in Robotics in Orthopedic Surgery. In addition to discussing this article, what we will really kind of focus on is essentially just doing a deeper dive on robotics in general in orthopedics and really focusing on total joint arthroplasty or total joint replacement surgery, where robotics is probably being used most in orthopedics. So for this episode, I'm excited to be joined by two friends. One is Dr. Ahmed Siddiqi. He's our senior author of the paper that we'll be discussing. Dr. Siddiqi is an assistant professor of orthopedic surgery at the Hackensack Meridian Medical School, where he specializes in total joint replacement and robotic surgery. And Dr. Jess Lonner is our guest expert. Dr. Lonner is a professor of orthopedic surgery at Thomas Jefferson University and a total joint surgeon at Rothman Orthopaedics and a key opinion leader in robotic total joint replacement surgery. So Ahmed, Jess, very excited to have both of you with me this evening to talk about robotics in orthopedic surgery, particularly total joint surgery. I couldn't think of two better people to have. So thank you guys for joining this evening.
Thanks. It should be a lot of fun.
Yeah, thanks for having us.
So before we get into the article, it's always good for everyone to kind of get to know you guys a little bit. So just want to ask you guys a couple background questions on each of you. So first question is, what drew you to your surgical specialty? So you're both orthopedic surgeons specializing in total joint replacement surgery. Dr. Siddiqi, you want to go first about kind of what drew you to that specialty?
Yeah, absolutely. So I went into residency with a pretty open mind, but I mean, joint replacement kind of drew me pretty quickly. The wide array of not only procedures, but the type of patients that we see, the 45-year-old triathlon athlete who's kind of worn out their knee and on the opposite end of the spectrum, 80-year-old grandma who just wants to be able to walk comfortably, pain-free. So seeing the different variety of patients and their activity levels and having a tangible solution to that, that was very, very rewarding, and that drew me pretty quickly.
How about you, Dr. Lonner?
Well, I actually went into orthopedics thinking I was going to be a hand surgeon. I could have worked with you all the time, Asif. I had done some research with one of your mentors when I was in medical school and was so impressed with the quality of cases, the complexity of cases. And then when I went into residency, the cases that I was seeing were a little bit more mundane and less interesting to me. At the same time, I had some mentors as a junior resident who are knee replacement specialists. And I thought the opportunity for innovation in the field and the complex cases that we're seeing were so intriguing for me that I decided pretty early during residency to pivot and to look for fellowships in knee reconstruction.
It's interesting that you both mentioned a couple things. One is mentorship. It's something that it's not lost on me that a huge part of surgical training and research in general is really driven around mentorship. You're taught by master surgeons who inspire you, and you're drawn to what they do, and that helps you kind of decide what you're going to do and what direction you're going to take. And we miss you in hand surgery, Jess, but total joint surgery is lucky to have had you. Let me ask a little bit about clinical research. Both of you are active researchers, and I think that that's something that obviously at SurgiColl we really value, and both of you I value as prolific and experienced and deliberate researchers. Jess, why don't you go first? What drew you to being actively involved in clinical research?
Well, much of it came from my experiences when I was a student, having worked with people who were innovative in their fields. And I enjoyed the process of writing papers. The first scientific paper I wrote was like an English paper. It didn't follow the scientific format. And I was told pretty quickly that I'd have to learn how to write scientific papers. So once I figured that out, I felt like I could be very efficient during my training during residency and combine a really busy clinical curriculum with my own personal academic pursuits. So I got involved in a number of clinical research studies that I've continued ever since. And at the moment, most of my research for me is done because if I only did knee replacement surgery, I think my life would be pretty monotonous. Whereas research allows me to expand my vision, to become creative, to think about how clinical challenges might be better solved, and to investigate things that we're only kind of considering as futuristic at this point. But it's nice to be able to impact the way we address problems now and hopefully more importantly in the future.
Ahmed, how about you?
Yeah, so similarly, I think, you mentioned mentorship before. So in residency, having really academic mentors, academic surgeons, not only, they're excellent clinically in the OR, but from an academic research standpoint. And that was very, very inspiring. So that was my first experience. It was early on in residency. And, you get your first publication in a good academic orthopedic journal, then you want to do it the second time, then you want to do it a third time, and then a fourth time, and then you realize that maybe you are making a difference. And it's similar to what Dr. Lonner was saying. I think once we get into a routine of doing hip replacements, knee replacements, and adult reconstruction, you really think about it from the patient perspective. Okay, we're doing great. We still have X, Y, and Z problems. How do we use what we're doing currently and think about how we want to improve that? And technology and research and technology is that front for the past couple of years. And using computer navigation, robotics, these are all ways that we're not only looking to be more efficient, but we're trying to hope that patients have a better, not only outcome, but a better experience overall. So seeing, being on the front line dealing with patients and then being able to investigate scientifically to see if there's other ways that we can further optimize the patient experience and outcomes, I think that's what really keeps me involved in clinical research.
Just a couple of comments to both of your answers. I think you're both shortchanging yourself a little bit in terms of your level of contribution and also the commitment it takes. I think most folks who train in surgery and orthopedic surgery in particular are trained at academic centers where there's academic faculty who are involved in research. But then to carry that into your practice, that number shrinks quite a lot in terms of those folks who are involved in clinical research during their practice. Actually, a very small percentage of, if you look at the broad swath of folks that practice different specialties, that speaks to both of your desire to continue to contribute and to advance your field, both for the sake of your patients, but also just for the broader specialty in general. So I applaud both of you for continuing to be thought leaders in the field of orthopedics, particularly robotics and total joint surgery. Let's switch gear. One more quick question, a little bit more fun, not less technical. I always like to ask folks, what is their most favorite, or you can take it the opposite way, your most hated medical TV show or movie, and why? There's always many of these right now. There's actually a bunch of shows out right now. We were discussing in the OR recently. So I'm curious, what do you guys think? Jess, you want to go first? What you and I are a little bit closer in age, so I'm curious what you're going to come up with.
Yeah. So, it's interesting. Since I've been in the field now for a couple decades, I actually don't really love to watch medical related shows so much. But I remember back when I was in med school, when I was in college and med school, there was a show that took place in Boston. It was called Saint Elsewhere. Mm-hmm. And it took place in a hospital that was an underfunded, poorly resourced hospital somewhere in Boston. I think it was South Boston.
We'd call that today a safety net hospital.
Yeah, that's right.
Right. Yeah.
And, somehow they made it work, and they had some brilliant doctors, as I recall. But the show was part drama, part comedy. They often made references to other shows that were on at the time or that had been on some years earlier. And that was the medical show that I had enjoyed watching the most.
So you're going back into the 80s, by the way, for that one.
Yeah, don't rub it in.
I definitely remember that show too, and that's a very good one. So I think that's a good pick. That's a good pick.
Okay.
Evans, how about yourself?
I think most of the recent shows are more filled for the, the romantic comedy and more for the drama more than the medical accuracy. But there's a few shows, The Resident kind of comes to mind, where, people are coming to the ER, they're taking them up to the OR, they're scrubbing in, and after they're scrubbed in, then they're putting their mask on. And I'm just like, wow, this is not very sterile or very accurate. So I actually try not to watch some of those shows just because they're highly inaccurate. And then patients come in saying, like, does this actually happen? Is this usually how it is? Referencing some of these shows. So I think they're more comedy more than anything else.
There's a show that came out recently that's getting a lot of attention called The Pit. It's on HBO right now. And I haven't watched a lot of medical shows in the past several years as well. But when I was in college and med school, ER was huge. And so it was kind of like coming full circle to watch that show with Noah Wiley again. And I'll give him credit. He was, I think, a producer on that show too. And it was pretty accurate medically. What wasn't accurate, I thought, was it was basically each episode was an hour. Each 1 hour episode was each episode was an hour of their shift. And that was quite a shift of 12 hours. That's like 6 months of ER experiences packed into your shift, but it was pretty entertaining. So anyways, it's always fun to kind of talk about, because I mean, whether you like it or not, these things are a big part of pop culture, and our patients watch them and they ask and they're curious about them. So anyways, let's jump into the article a little bit. So Ahmed, you did a great job on this article where you're reviewing with your co-authors the increasing use of robotics across orthopedic surgery. And in your review of this literature, which is relatively new, what trends did you see developing? So look kind of more broadly in orthopedics. What did you notice as far as trends?
So not only in, hip and knee replacement probably has the most experience and usage in robotic technology, and I think that continues to grow, especially on the knee side of things. But what was really interesting is in a lot of subspecialties, navigation and robotics is growing as well. So when we did the deeper dive in orthopedic oncology, there were some early technologies available. I thought that was kind of cool because those are some, a little bit less planned procedures, and all of a sudden you can plan it a little bit better. Same thing with upper extremity, same thing with spine. Spine's been kind of up and coming as well. So not just the hip and knee replacements, some of the, other surgeons say they don't need technology, robotics. It's a phase, it's a fad, it's going to phase out. But if you look at not just within hip and, adult reconstruction, it's all the subspecialties that are tremendously not only growing, but there's a strong interest in it. So I don't think this is a phase or a fad. I think this is here to stay. I think what we just have to figure out is what the next level is going to be over the next decade, 2 decades, and what that translates into.
Well, let's build off that answer, and I think it's a good segue to my next question, which is for Jess. So robotics in total joint arthroplasty surgery isn't new. We were starting to fool around with that even when I was a resident in the early 2000s in terms of at least with navigation. So where have you seen kind of the arc of development of robotics, and where do you see going forward, like utilization being most prominent, or where most of growth is going to be at?
So you're definitely right that robots are not new, and it's no longer just a fad. There have been so many fads in joint replacement surgery, like conventional navigation, that never really went anywhere other than in select centers. But it was certainly an interesting precursor to the explosion of robotics. But robots have been out now. The first robot in clinical use in the United States was FDA approved in around 2005, 2006. A friend of mine, Martin Roach, who practiced down in Fort Lauderdale, was involved with a small little startup at the time called Mako. They were developed in a garage in Fort Lauderdale. And he knew I was interested in partial knees. That robot was developed for use in unicompartmental knee arthroplasties. And he reached out to me. He knew I had an interest in partial knees. He thought I was interested in innovation. And when he mentioned the concept of robotics, I thought it was a little bit crazy. I couldn't imagine why anyone would want to use a robot to help them do a knee replacement. But I looked at the technology and I thought it was very interesting. So I went to a lab in Newark, New Jersey, I had some great paella, which was absolutely delicious. I actually had it for lunch and dinner the following night. And after I spent time in the lab, I thought this might be the future of how we do unis. And I toiled in the space for a number of years, and there was very little enthusiasm amongst the orthopedic community. All our colleagues, the gray-haired colleagues who ran the important societies, would give me a token lecture on robotics for a number of years, but there were very few adopters. It took my hospital about a year and a half to agree to purchase the robot because at the time it cost the hospital over $1 million to acquire a robotic system. You had to add 100 cases to your clinical volume to pay that off. So it was a tough sell, but it was really the start of a really interesting pathway. And it wasn't until about 2014, when I think there was a pretty big explosion in terms of the use of robotics in the United States and worldwide. I think there were a few reasons for that. One is that for the initial 7 years or so, there was just one company selling a robot. Now, all of a sudden, there were two or three, and eventually a fourth robot coming to the market. So there were more opportunities to acquire a system. Most of the robots were being used for unis at the time, but in 2013 or so, these began to be used for total knees, bought in the market. But I think one of the more important drivers of increasing volume was around that time. If you look at the demographic of the surgeons that were specializing in knee replacement surgery and hip surgery, were 55 years old and younger. And these were the technologically interested surgeons, the gray-haired surgeons who had been doing knee replacements for so long, so well, but couldn't imagine going beyond the conventional tools. They had no interest. But now all of a sudden there was a whole new younger population of surgeons who were intrigued by technology. And I think that really spearheaded the increased trajectory in the space.
Can I ask a follow-up question to that, Jess? A couple of things. So first of all, my first question is, you mentioned this, but just if you could dig deeper a little bit. So was most of the growth initially in robotics with unis, and why was that? And then two, as more companies came into the market, was their competition kind of driving some innovation?
Yeah, so initially the robots being developed were for unis because it was known that even small errors in component positioning or soft tissue imbalance in unis would predispose to failures. So it was considered a niche type procedure for unis only. And quite honestly, when companies started rolling out their platforms for total knees, I thought, oh boy, here we go again. I couldn't quite imagine a big need because there was data in total knees that showed that more variability in component position could be well tolerated by patients. But then as the devices started rolling out, innovation started improving, costs started coming down, surgical efficiency started improving. And I realized, maybe there's just a huge paradigm shift going on. It's not just the improvement in alignment, but maybe there are other beneficial features of robotics too.
Got it. Okay. Yeah. Is it expanding past unis now? And when you say unis, for those who may not know, could you just explain what that is? And then secondly, is it kind of growing beyond that space into your traditional total joint?
Yes. So a uni is sort of a slang name for a unicompartmental knee arthroplasty, which is a partial knee replacement. And now the companies all offer platforms, total knee replacement. In fact, the primary use of robotics in orthopedics are now in total knees. Partial knees still robots are still being used for partial knees. They're being used to a smaller extent in total hips. Ahmed mentioned spine, which I think is probably the second most common orthopedic area behind knees. They're expanding into shoulders, and eventually other areas are going to probably have a robotic platform.
Okay, I got it. Emma, let me ask you a question. So, building off what Jess said, the term robotics is an interesting term, and I think conjures up a myriad of things when we say that, and I wonder, when you say that to your patients about robotic surgery, what they might be thinking. Particularly, we have such a rich sci-fi pop culture. I can only imagine what people are thinking. So, how do you communicate to them what robotic surgery is, so they have some relative understanding what it is, or do you not? Or do you say, listen, it's like the holodeck on Star Trek, and that's what I'm doing?
No, so patients actually are very interested in that. And the first thing that they usually say is like, yeah, I'm okay with the robotics, but like you're still doing the surgery, right? There's not just a robot in the room and you're outside the room controlling it. And the other thing is, I think with, GYN and urology and general surgery using the Da Vinci or another more different type of robot where, the surgeon is not, they're kind of on a separate area using almost like a console, and patients undergo that. And when they understand that, they think it's the same thing. And it's just kind of reestablishing expectations and what the technology is. And the first thing I say is it's not like it is in some of the other subspecialties. This is just a tool that I use that's guided, and it helps execute the plan that we set forth. So the brain behind it is still the surgeon. The plan is still the surgeon, and it's just a tool we use to help execute that plan. And it's precise and it's accurate. And it gets the target, almost 99.9% of the time that we set forth. So I really highlight on the accuracy and the precision of executing the plan. And then patients really understand that. But I think the biggest thing that they want to know is that the surgeon, or such as myself, we're still controlling the tools, and it's not just acting autonomously without any thought behind it.
Got it.
Asif, it's very interesting. So to Ahmed's point, it's patients equate the success of Da Vinci, which has been proven for a wide array of conditions, prostate, you name it. And they think that because of that success, the robot in knee replacement surgery would provide equal success. But when you ask the patients, how does the robot work? What do you expect it to do? Why do you think it makes things better, or does it make it better? Turns out about 50% of the patients have no idea why it might be better, how it works. But 50% of our patients want their surgery done, their knee replacement surgery done with robotic assistance. They don't understand it, but they know it's good in that other space, so it's got to be good in knee replacement surgery.
So I want to drill down a little bit more. So two parts to this question. So one is, and Jess, why don't you tackle it first? To build off what Ahmed said, how do you tell people about robotic surgery in terms of explaining it? Is it just something you discussed? You show them pictures, a video, etc.? And two, has there been research showing that patients' perceptions of robotics are, let's just say, varied?
So patients will now oftentimes come in asking for robotic surgery. I often don't bring up my surgical techniques with patients unless they inquire about how we're planning to do the surgery. And if they ask, we discuss it, and we'll go into various levels of depth depending on how much they want to hear, how much they want to discuss it. I do have a frank discussion with them about what my perceived benefits of robotics are, because when we were innovating robotics, our goal was to improve alignment of the components and improve the soft tissue balancing. And we've shown that to happen. And Ahmed mentioned that earlier, and also in his recent review, that study after study after study, whether we're talking about partial knees, unis, or total knees, have shown exactly that: improved alignment and improved soft tissue balancing. However, in the hands of expert high volume total knee replacement surgeons or high volume skilled unicompartmental knee replacement surgeons, the data is less clear on the benefits of robotics in terms of improving function for the patients or improving implant durability. In reality, high volume, high skilled knee replacement specialists will get really good outcomes. But what some of the very important international registries are showing is that in the hands of less experienced, less specialized knee replacement surgeons, the durability of the implants is improved with the use of robotics. And I tell the patients that because, I need to be honest with them. Their expectations have to be on par with what the reality is. But what we have shown, and we've seen this in both unis and total knees, is that in the hands of a specialist knee replacement surgeon like myself, who still does a lot of conventional total knees, what we have found and what others have found is that even though the outcomes in terms of function and durability might be the same between knees done with robotics and knees done conventionally with conventional tools, the initial 6 weeks and the initial 3 months, we're seeing that there's improvement in function. So patients in the initial few months after knee replacement are a little bit further along in their recovery when we've done their surgeries robotically. So that's important, particularly since half of our patients are still working age. And even our patients who aren't working anymore, they're still active. They want to be out in the community and playing pickleball and doing their things that they enjoy. And so if we have a tool that allows for a quicker recovery, even if conventional patients catch up, I think that's a big advantage.
But Jess, when you say that, and so we're getting into the outcomes part of things, which is great, and I think that's really the big bugaboo in this, right? So are the outcomes better, right? It sounds fascinating. It sounds interesting. I'm sure patients are very intrigued by that, and there's probably some implicit bias, I would say, positively towards the use of robotics, likely that patients carry because of the assumed scientific, or innovativeness or advancedness or futuristicness of it, right? But when you're mentioning these studies, Jess, is that difference controlling for surgeon experience? For example, in your hands, doing this for over 25 years, I would argue that you could do this with or without robotic surgery, with probably equal outcomes, equal durability.
Yes, and that's what we've seen. That's why I never want to take the light away from colleagues of mine across the country, in our own area even, who are very good knee replacement surgeons, but they may not be using robotics. They're still good surgeons. Their outcomes are still good. And in reality, at a year, their patients' function and my patients' function with the robot are probably equivalent. But with the robot, in the hands of all of those talented surgeons, with the robot, the recovery will be a little bit accelerated at 6 weeks and 3 months.
Emma, do you want to add anything to that in terms of the effect of robotics in surgical outcomes? The impact, I should say, the impact of robotics.
Yeah, I think, just like Dr. Lonner said, I have frank discussions with my patients as well and kind of tell them the endpoint might be the same, but the journey there might be a little bit quicker. It might be a little bit expedited, but at 6 months, 1 year, they're pretty much very, very similar. The other thing that I really highlight when it comes to value of robotics is just the precision and the accuracy and the fact that it decreases outliers. So if you have a higher chance of getting the target that you want to hit, regardless of the number of cases that you do, because when patients come to high volume surgeons, they know that that they're they might be one of 10 cases in that day, and and I don't beat around the bush. I say I have the same level of precision and accuracy and to fulfill the plan, whether you're case number 1 or you're case number 10 or 12 that day. That variability does not change, and human fatigue is a real thing. And this sort of eliminates some of that from a planning perspective very, very precisely, because I can't tell you the number of times patients say, well, I want to be the first or second case of the day because if I'm going to be 9 or 10, you're going to be tired. And I say, I do get a little fatigue, but using technology prevents me from letting that fatigue affect the precision or the plan, and helps me execute the plan as if you're the first case of the day. And I also comment on just longevity of surgeons, because the patients develop a rapport and they want you around forever as long as they're around. And for the patients that dive a little bit deeper, I say ergonomically, for me specifically, it helps me stand up a little bit better. It's a little bit less taxing on my shoulders, on my hands, and ergonomically, I think it's pretty friendly using technology. And all these things combined, I think, is beyond just the patient outcomes, how long a knee is going to last. I think if you take this whole thing as a whole, I think the value is what I really drive to patients, and most of the time they're all on board with that.
I mean, let me ask you to expand on a couple points there. So one is that I think people have different, even amongst surgeons and researchers and folks listening to this, they may not know how you're actually deploying robotics, right? So in your OR for a total joint case, let's just say total knee, what is the role of the robot? What is it telling you, and or what is it physically doing, if anything?
So
I think Ahmed froze.
Yeah.
Ahmed, you froze. I'm going to bring that question back to you in a second, but Jess, let me ask you that same question. So not everyone's really familiar with how robotics work necessarily, even among surgeons and researchers, and there's different types of robotics, right? So how do you explain, or how can you explain to me how you deploy robotics in your cases? Are they telling you where to make the cuts? Are they physically making the cuts? How would you describe it?
So most robots on the market, except one right now, are semi-autonomous, meaning that they're collaborative. They work in conjunction with the surgeon. The surgeon develops the plan. We determine how we want to orient the components, how we want to balance the soft tissues, and then decide where we want to position our robotic cutting tools to make our resections, to prepare the bone, to position our components in the desired orientations. There's one system out there on the market that's autonomous, meaning we do the planning, but once our planning is done, we push a button and the robot does the bone preparation autonomously. That's the only one on the market. Maybe in the next 10 years, more will be autonomous. Patients are a little bit scared that the robots will do too much, but these current robots have proven to be safe, and we've looked at thousands of semi-autonomous robotic cases, and there's very little risk for injury caused by the tools because we're overseeing everything.
So the autonomous ones, they're making the cuts. They are mindful of, say, they're making the tibial cut in terms of not going too posterior relative to the great vessels, the popliteal vessels, not going too medial lateral relative to your collaterals, et cetera. There's enough sensibility and precision to the autonomous robots.
Yes, in the 90s, when the autonomous robot was first introduced in Europe and in Asia, there were a few reports of soft tissue injuries caused by the robot. So damage to some tendons around the knee. They were using it in the hip as well. There were some reports of damage to some of the hip tendons. But I think in reality, the surgeons were probably not exposing a broad enough area for the robot. Incidentally, that robot was approved more recently in the United States by the FDA. And that robot is actually housed in the Smithsonian Institute. It was developed by a surgeon in California who's a friend named Bill Barger. And he took a lot of heat for developing this sci-fi device. But it was very unique, and certainly was very influential for those of us who've really grown in the field of robotics.
Wow. Well, we are getting close to wrapping up, but I want to ask one more question. Ahmed, we were talking, I know you dropped off for a second because of probably Wi-Fi, but that's welcome back. Mm-hmm. We were talking a little bit about the different types of robotics, and most I understand are not autonomous. They're working in concert with you as a surgeon, maybe directing and or making some of the cuts versus making most of the cuts, right? What are your thoughts on the autonomous versus not autonomous currently, and what do you think the future is going to be relative to that?
I don't think robots in the realm of orthopedic surgery and joint replacements will be fully autonomous. I think the concept of soft tissue protection, I think, is still going to be a big one. I think you can still highlight where the soft tissue anatomy is in the knees, but it's never perfect. And to allow for some of that variability, I think the semi-autonomous is probably where it's going to be. I think surgeons are still going to want to have some sort of control. I just don't envision the day where the robots are just acting completely independently. I think that kind of takes away from the attraction of using technologies in this space.
Yeah, no, I agree. I'm trying to think it in my mind, my comfort level with that. And it does take away kind of much of our role and purpose, in the OR in a lot of ways. It's almost like those those autonomous cars that drive themselves now. But I guess in the right situation, it makes sense. But I think where both of you are really kind of on the tip of the spear in terms of this evolving technology. And I'm confident enough to say that we're probably not done writing this chapter. And there's a lot coming relative to robotics in orthopedics and orthopedic surgery. So my final question to each of you is, what do you think is, and again, because we are focusing on scientific research here, and part of your role is to inspire future researchers and future projects. Ahmed, why don't you go first? What do you think are some future directions for research on this topic? Where do we need to continue to investigate?
I think soft tissue balancing and is going to continue to be the driver. How do we, from the knee replacement perspective, how do we figure out what soft tissue balance is going to be optimized for that individual patient? For that patient that has a varus thrust the way they're walking versus a valgus thrust, and not every deformity is the same. So not every 3 degrees varus is the same, basically. So if we can really tackle individualized soft tissue balancing and a target for that type of phenotype of patients, I think that's going to be pretty groundbreaking.
Jess, what's your take on the same question in terms of future direction?
So actually, very similar to what Ahmed was just saying. Right now, we're amassing a library of information, and we're trying to figure out how some of the intraoperative decisions that we make are influencing intraoperative decisions like soft tissue balance that Ahmed mentioned, or component positioning, how those influence function and how they might influence longer term durability. And it's possible that once we get a large enough body of information in that regard, we can then start to use artificial intelligence to inform some of our intraoperative decisions. And maybe at that point, then we can start to see expansion of autonomous systems, or at least, if not autonomous, then at least automated processes that will more efficiently dial in those parameters, like soft tissue balance and like component positioning. It'd be very interesting.
Yeah, I suspect there's a lot more to come, and there's a really a ripe area for scientific innovation and discovery and research. With that, I'd love to thank both of you for the discussion and your expertise and all your teaching. In closing, at SurgiColl, we believe that open access publishing is the future of scientific publishing. It keeps costs down, it allows the authors to maintain the ownership of their work, and most importantly, it facilitates expeditious dissemination of the author's research to anyone with internet access around the world with no requirement to purchase access or pay for a subscription. So with that, thank you for joining us, and until next time, goodbye.